But for tonight, we are celebrating the award of the Herschel Medal to Professor Quarraisha Abdool Karim, who is the Associate Director of Quarraisha. Allow me to say just a few words to introduce her. We are delighted that we can award her this medal. She is extremely distinguished as a scientist and absolutely a multidisciplinary, transdisciplinary expert. Listen to a little of her career. She holds a number of degrees, including a PhD and 2 DSCs. She's a South African epidemiologist and an NRF A-rated scientist, and she has made pioneering contributions over more than 30 years to studies on HIV, and in particular, preventing HIV infection in adolescent girls and women. And in particular, you may know her for the landmark Quarraisha 004 trial that demonstrated antiretrovirals for preventing HIV infection. She has also played a central role in training over 600 scientists with a strong science base, all leading to responses to the HIV/AIDS crisis and tuberculosis through discovery and implementation of scientific research. She is a very strong advocate of the rights of people, and in particular, those who are living with HIV and AIDS and women. She is also the co-founder and associate scientific director of Quarraisha and a professor in clinical epidemiology for Columbia University and pro-vice chancellor for African health at the University of KwaZulu-Natal, among other distinguished roles that she has. We are very proud that she is a fellow of our Royal Society of South Africa, and she is also a fellow of the African Academy of Science, the World Academy of Science, and the Academy of Science of South Africa. So with that glittering CV, I'm absolutely delighted to invite Professor Abdool Karim to present her lecture to us this evening, which is titled South Africa's COVID-19 Trials and Tribulations. I'm really looking forward to hearing this. It's something that interests me enormously, and obviously from the large number of people here, it interests a number of people. So Quarraisha, over to you. When we've listened to your talk, there will be an opportunity for the audience to ask questions. So I would ask you, please, if you have questions during the talk, to put them into the chat section of the Zoom interface, or else there will be an opportunity for you to put up a hand later after the talk and ask a few questions. Please do ensure that your microphone remains on mute during the talk, and then when you are going to speak later, you'll need to switch it on. Quarraisha, over to you. Thank you so much.
Thank you very much, Professor Burton, for that very warm and generous introduction. Greetings, friends and colleagues. I want to start by thanking the Royal Society of South Africa for the honor of bestowing me the 2021 recipient of the John F.W. Herschel Gold Medal. And I use this opportunity to congratulate Professor Barber and also the Marlin awardees for 2021. What makes this award for me so special is that Sir John Herschel was an embodiment that knowledge was universal and belonged to everyone, in addition to his interdisciplinary approach to knowledge generation. It is also truly humbling to join the cohort of recipients of eminent South African scientists who've made a huge impact on society through science locally and globally. So I should add this, I've had the privilege to attend a few of these lectures in previous years, and this lecture is usually delivered over a wonderful dinner with fellows and no slides. Thanks to COVID-19, we are gathered here today virtually, with the silver lining being that this lecture can be accessed by a broader audience, but unfortunately, no dinner and no slides. While most of my scientific contributions in the past 3 decades has focused, as Prof. Burton outlined, on HIV/AIDS, and my engagement with COVID-19, like for most, is recent, I was requested to focus my talk on what has dominated our lives for the past 18 months, namely COVID-19. I thank the Royal Society of South Africa for the opportunity to address you on the trials and tribulations of access to COVID-19 vaccines. It's a useful reminder that South Africa is not alone in facing these challenges. And even though its challenges were manifold and varied in thwarting the South African government's vaccine commitments and efforts between September and July 2021, we are now in a much better place in terms of having secured sufficient doses of vaccines and have the vaccine rollout ongoing. But some of these challenges are shared by the majority of low and middle income countries in the face of a global and ongoing threat. In the interest of time, I will touch on 5 key elements of the challenges relating to vaccinating poor countries and what the opportunities are to alter the current COVID-19 trajectories and be better prepared for future emerging and re-emerging pandemics, and not forgetting ongoing epidemics that we have of HIV, TB, Ebola, amongst others. So I will cover about 5 issues in this presentation. The first is how to secure adequate vaccine doses for poor countries within a context of a non-existent vaccine distribution system, and the exacerbation of dose shortages by booster doses for the rich. Secondly, how to develop vaccine self-sufficiency in poor countries. Thirdly, getting from vaccines to vaccinating people. Monitoring vaccine effectiveness in the context of concerns about variants. And finally, how we can each contribute to implementing the World Health Organization's global vaccine strategy towards vaccine equity. So while the COVID-19 pandemic has reminded us very sharply of our mutual interdependence and our shared vulnerability as human beings, the devastating and ongoing loss of lives and livelihoods has impacted poor countries disproportionately. Barely 9 months after the discovery of SARS-CoV-2 and 8 months since the World Health Organization declaration of SARS-CoV-2 as a public health emergency of international concern, the announcement of several efficacious COVID-19 vaccines was met with great hope and of some return to pre-COVID normality, and set a new bar for the speed of knowledge generation and the production of life-saving technologies. However, inequitable vaccine access rapidly reared its head and reminded us of a world divided by the haves and the have-nots, best captured by the United Nations Secretary General Antonio Guterres at the most recent UN General Assembly, and I quote, "We have passed the science test, but we are getting an F in ethics," end quote. So how were the vital COVID-19 vaccines secured? In short, through 5 disjointed separate ways. Firstly, not surprisingly, those countries that developed their own vaccines, largely through funds from taxpayers, were within about a month of announcement of vaccine efficacy results vaccinating their citizens. These include countries like the United States of America, Germany, India, China, Russia, and the United Kingdom. Next were countries who were able to secure doses through advanced market commitments, that is, purchasing vaccines at risk even before the outcomes of efficacy trials were known. These countries include Israel, Denmark, Canada, and Australia. In some instances, for example, Canada secured more than 9 doses for each citizen. Next, countries like the United Arab Emirates, Turkey, Egypt, Morocco, and Chile were able to secure doses through vaccine diplomacy or some quid pro quo type arrangement. Fourthly, the majority of the countries entered into bilateral agreements that were shaped by market forces of supply and demand. Lastly, and at the end of the queue, was COVAX, Ironically, the mechanism that was set up to ensure global equity in access, particularly for poor countries. In June 2021, an analysis by The Economist illustrated that there were enough vaccine doses for all countries if the rich ones share. But what we continue to see is that 50% of the world's supply of vaccines has been reserved for 15% of its population. This lack of access to vaccines in poor communities can best be described as vaccine nationalism by wealthy countries. Even though Africa participated in several vaccine efficacy trials, it had to join the end of the queue for access to vaccine doses, and in several instances has had to pay a higher price for the same doses of vaccines. By the end of September 2021, over 6.2 billion people had received at least one dose of a vaccine. The majority of these doses were distributed in industrialized countries, with Africans having received less than 5% of vaccine doses. While we continue to see shortages of access to vaccine doses, we see wastage in rich countries. In the USA, there are millions of doses set to expire. Since December 2020, about 1 million doses have gone to waste. Instead of being a global public good, COVID-19 vaccines have become a commodity to buy and sell and use for political benefit, creating inequities across the globe. Vaccine inequities exist not only between countries, but also within countries. For example, in New Zealand, despite having one of the highest vaccine coverage rates in the world, Maori and Pacific peoples have about 20% vaccination rates. In the USA, the differences between whites, blacks, and Hispanics are also stark, and concerted efforts are underway to bridge these gaps. But there's a new threat to vaccine equity in the form of booster dosing. Booster dosing plans in rich countries have recreated global shortages and exacerbated vaccine inequity. While booster doses are warranted for severely immune-compromised patients and the elderly, rich countries are stockpiling doses for widespread boosters based on waning immunity, even though evidence for hospitalization and severe disease is not convincing. The World Health Organization Director General called on a moratorium on booster vaccine shots until at least 10% of the population of every country has been vaccinated, particularly healthcare workers and the elderly. The question is, can we do both? For every dose going to a rich country means one less dose for COVAX. For example, Africa currently faces a 470 million vaccine dose shortfall, and COVAX is unlikely to meet its 2021 delivery target. It is worth reminding ourselves that all countries across the globe are experiencing excess deaths and the pain that goes with that due to COVID-19, including Africa. And while rich countries are starting to see declines in excess deaths due to COVID-19, Africa and many poor countries are not. With just 3.6% of the population in Africa vaccinated, it is way behind in reaching its targets for vaccination coverage. There is some hope in plans that are being put into place that will enable Africa to have initiatives to make vaccines. Of note is the partnership of the African vaccine manufacturing by the Africa CDC, the PAVM, that was launched in mid-April 2021 with 1.2 billion euro support from the European Union. WHO and COVAX partners are working with the South African Consortium and the Africa CDC to establish its first COVID mRNA vaccine technology transfer hub. While this may not address the immediate dose shortage needs, in the longer term, this aspirational goal may be realized. Existing fill and finish capacity are an important starting point, but needs to be expanded to include vaccine development capacity. Local fill and finish commitments in itself are also no guarantee to access to doses, as we recently learned in South Africa, where about 31 million doses of J&J vaccines bottled by Aspen in South Africa was exported to Europe while we were left waiting. Another consideration is the sharing of intellectual property rights and technical know-how that is essential for countries to make pandemic vaccines a public good. There are a small growing number of rich countries recognizing that everyone benefits if vaccine manufacturing is distributed evenly around the world, and that patent waivers on vaccines is right and fair, particularly under pandemic situations and emergencies and disasters. While South Africa has now secured sufficient doses of vaccines and supply of those vaccines are more stable and consistent, this is not the case for the rest of the world, and certainly not for Africa, where we have to strengthen our advocacy efforts to close this gap. But securing sufficient doses of vaccines is an important first step, but not sufficient on its own. There are related challenges to getting vaccines into the arms of people. In the interest of time, I will highlight a logistics and operational challenge and a behavioral challenge. So what are some of the health systems challenges? While not exhaustive, some of these in low middle income countries include that this is a completely new service, as there's been no generalized adult vaccine program prior to this. Inadequate shipping and storage logistics, including cold chain issues for some vaccines, lack of funds and trained professionals to administer vaccines, inability to capture crucial data or to print and distribute immunization cards, and limited ability to track and report adverse effects following vaccination. Some of the behavioral challenges that we can look at and that I will highlight comes from experience from market analysis of new product adoption that segments the target population into 5 groups. The first are the innovators. So these are the individuals who are so enthusiastic about what is new and what is there and about to come even before, and will find any way to get vaccinated, in some instances, even going to countries where they can access the vaccine. Then we have early adopters, and these are those who can see the potential of the new technology and who will spend even a whole night waiting for the first store to open and be first in line. And again, with vaccines, we've seen that, the early adopters. Then we have the early majority, who are the pragmatists who want to get vaccinated and do get vaccinated at their convenience. Then we have the late majority, and these are the conservatives and hesitants who need some more incentives or mandates and other things to be encouraged and supported to adopt the vaccines. And then lastly, we have the laggards, about 5 to 10% of the population who are unlikely to ever get vaccinated, but may benefit from the rest of the population, excuse me, getting vaccinated. Now, there's no one-size-fits-all approach, and at different stages of vaccination rollout, the need to adapt approaches to be more suitable for the specific segment of the population who need to be reached, need to be developed and utilized. And these include engaging local leadership, taking vaccines into workplaces or the community, more campaign-style approaches, more information and education efforts, more flexible service hours, peer support, and diverse access points. But I would like to now move on to variants of concern. And we've all seen and experienced the clinical and public health impact of SARS-CoV-2 variants locally and globally. And notably, the surges of COVID-19 in the last quarter of 2020 in South Africa, for example, in most of 2021, initially in India, the UK, and then spreading across the globe due to the emergence of variants of concern. These variants were first identified in South Africa, and then in the UK, Brazil, and in India. And what they've done is change the COVID-19 endgame. For example, the more recent Delta virus surges, even in countries with high vaccination coverage rates, have highlighted the new battle lines between vaccines and the variants. In South Africa, the conduct of vaccine trials during the emergence of the Beta variant and its impact on vaccine efficacy informed vaccine choices and underscores the need for ongoing monitoring of variants and for correlates of protection as we move forward to understand vaccine efficacy and for adapting our strategies to be more effective. Our hope lies in our vaccination efforts outdoing that of the virus. And as long as the virus is outdoing us, we have little hope for return to any kind of normality. So how do we move forward? There's very clear guidance provided by the World Health Organization Global Vaccine Strategy to achieve global vaccination by mid-2022, developed on 4 underlying principles of equity, quality, integration, and inclusivity. COVID-19 vaccine coverage rate targets were set at 10% by September, 40% by December 2021, and 70% by June 2022. We have missed the September 2021 target of 10%, but together we can achieve the December 2021 targets. Each of us has an important role to play in ensuring access to vaccine doses for poor countries and ensuring that doses get into arms. And this does not matter whether you are a scientist, whether you are an ordinary citizen in the community, or whatever your role is in society. We have achieved such a laudable goal previously with another pandemic. A key lesson from HIV that underscores the importance of mutual interdependence is best captured in the UNAIDS 2015 report on how AIDS changed everything. I quote, "The AIDS movement demonstrates that with a shared vision, shared responsibility, and through global solidarity and leadership of people living with HIV, affected communities, and individual action, we can change the course of history." Close quote. Through global solidarity captured at the 13th International AIDS Conference held in Durban, South Africa, leading to the establishment of structures such as the Global Fund for AIDS, TB, Malaria, UNITAID, PEPFAR, and government investments, access to antiretroviral treatment changed the face of AIDS from an inevitably fatal condition to one that is chronic and manageable. Today, over 30 million people across the globe have access to antiretroviral treatment. I'd like to conclude in the words of Pope Francis in an editorial on COVID-19 published in the New York Times in 2020. The pandemic has posed the paradox that while we are more connected, we are also more divided. To come out of this crisis better, we have to recover the knowledge that as a people, we have a shared destination. The pandemic has reminded us that no one is saved alone. What ties us to one another is what we call solidarity. Solidarity is more than acts of generosity, as important as they are. It is the call to embrace the reality that we are bound by bonds of reciprocity. I thank you very much for your attention.
Thank you very much, Quarraisha, for that fascinating and typically broad cross-disciplinary view with so many aspects of this whole situation we find ourselves in. I would like to invite the audience, if anybody would like to put up a hand to ask a question. The way you do it is along the bottom of your screen There are two, it depends on how your screen is configured, either where there's reactions or whether it's where it says more, and then click on that. And you will find a place where you can put up a hand. Alternatively, you can put a question into the chat box, or if your hand, your Zoom hand is not working, you can actually just turn on your microphone and indicate, and I probably will see it. I see we have close on 70 people, so it's a little difficult to manage that. But please do go ahead and make your comments or questions if you would like to. And I have one or two, but let me invite them from the audience first. And the first one is from Zinjay Ma. If you would like to turn on your microphone and go ahead.
Hello, yes, Professor. Yeah, can you hear me?
Yes, we can.
Okay, great. Yeah, thank you for this very nice talk. I'm an astronomer, and I can see there's a lot of astronomer friends also here in the participant list. Interestingly, to meet a friend, here virtually. So yeah, my question is that currently we are experiencing this kind of the low kind of region between the two high tide, so basically a low transmission period. But I can see, that there was an analysis showing wave after wave after wave. So is there any projection in the future about perhaps a new mutation, a new kind of variation, or something may impact us, in the near future, about another wave, perhaps, and what is the prospect for us next year, for instance? Yeah, thank you. Yeah.
Quarraisha, go ahead.
Prof. Burton, do you want me to answer after each question, or would you like to
take that one? Take that one. There doesn't seem to be another one right now, so go ahead with that one.
Okay. So thanks, Dr. Ma. That's a great question. And I think as we've tracked the pandemic and the epidemic within countries, we've certainly seen these waves, repeated waves, and we've seen almost a predictable number of days between waves. And I think what's important is to recognize that our vaccination efforts have been more recent. And one, and two is that those vaccine coverage rates are unequal. And as long as we have unequal vaccine coverage rates, as we've seen with the Delta variant, we can see escape mutants, and we will see new mutations arising. So the virus, as we've seen, mutates within countries, and that spreads fairly rapidly. So if I had crystal ball, I would, and based on the evidence, say it's likely that we're going to have another wave. Now, will that new wave that we see be within the same time period that we've seen with previous waves? Will it be longer? Will it be more transmissible or not? I think that time will be able to verify that. But from everything we know, it is likely that given what we have and the current situation globally, it is a very high possibility. Thank you.
Thank you. We have Barry Sharp. If you would like to ask your question. Thank you, Barry. Welcome.
Thanks very much. And first of all, congratulations, Quarraisha, for a really excellent talk. Really found it fascinating, particularly bridging the ethics and the science. I just wonder what your comment would be. Do you think that our present generation of vaccines, we will, be able to lift ourselves from a containment phase, where we still have to kind of rely on the non-pharmaceutical interventions to augment vaccine immunity, to a control phase where we can, I think, what everybody would like to do is get back to our pre-COVID existence. But do you think that is possible with our current generation of vaccines? Do you not need to kind of advance to a second generation, which maybe affects mucosal immunity, maybe is variant proof and so on? Thank you.
Thanks very much, Barry, for your warm message of congratulations and also for your excellent question. If I was not the keynote speaker, I would have directed this very question to you, as I think you a best place to answer it. But I think, Barry, when with most innovations, when we have the first generation, we always try to improve it. We need to understand better what we have and advance that. And I think that with time, when you think about most, the longest cohorts we have of vaccinated individuals is just over 6 months. And I think we're still learning what parts of the immune response is more important or what combinations are important. So I agree with you that new generation vaccines should not just be about delivering better forms of what we already have, but looking at how do we enhance the product. And I think that, the discussions underway, the publications in several journals about trying to cover all of the coronaviruses so that we're not responding to one virus at a time, and that these more broad coverage vaccines will bring us the stability. But I think also to underscore that while we can have better and better vaccines, the real and true impact of vaccines on epidemics and pandemics is from the vaccination. It's getting those vaccines. And so that remains our challenge with the existing cohort of vaccines that we have, is that we don't have enough coverage rates in more than a few countries. And I think in parallel, as we improve the vaccines we have and think about new generation vaccines that can offer us protection beyond SARS-CoV-2, we certainly should be matching that, if not exceeding it. And the point that I made earlier about balancing the speed with which we can do our vaccination so that we get ahead of the virus. And right now, what we see is that the virus is ahead of us. And as long as the virus remains ahead of us, then our hopes for whatever that normality is, I think, remains fairly small.
Thank you. Then we have a question from Rashila Mudley, if you would like to ask your question.
Hi, Quarraisha. Can you hear me?
Yes.
Yes, we can.
Hi, it's Rashila Mudley from the School of Chemistry and Physics at UKZN. Thank you for that wonderful talk. To start, I would like to tell you that you are one of my inspirations. So my question to you is, aside from the vaccine inequalities, there are also the system of red listing, and South Africa being one of the red listed countries. And the status of the countries is constantly evaluated. Including the red listing, there's also the banning of international travel if you appear, and even if you don't appear on the red list, there's quarantine issues and so on. I would like to hear your opinion on this mechanism, especially by first world countries on the red list countries. Thank you.
Thank you very much, Sheila. And I think that, firstly, I want to recognize that we're not just dealing with vaccine inequalities. There are also human rights violations that are going on. There are big disparities in terms of livelihoods lost, and other disparities that emanate and precede, that emanate from the COVID pandemic, but also precede the COVID pandemic. And it is very sad when we started off initially as one voice, one people, one world in terms of our shared vulnerabilities and interconnectedness, that we're starting to see these divisions appear again. And some of those are being expressed, as you said, in terms of travel restrictions. And those restrictions that are being placed by different countries are not always transparent. And I'm thinking with the red listing in the UK, like why and what. So this lack of transparency in terms of why some countries are instituting some measures, why some countries are allowing travel and some not, why some are recognizing some vaccines and not other vaccines, and some instituting quarantines and isolations, even if you're vaccinated, is something that's not immediately apparent. And I'd say that I think that that it is important for us to use the evidence we have in making decisions. And while in the COVID response, science has played an important role in informing political decisions, it's not always been the way decisions ultimately get made. And I think the examples that you've highlighted are some good examples of the need for evidence for decisions, and whether those are scientifically based or or other reasons for restricting movements of people that are being used under the guise of COVID-19 restrictions.
Thank you. I see we have a question from Professor Nigel Bennett. Nigel, please go ahead.
Thank you very much, Professor Abdool Karim. I really enjoyed your talk, and congratulations on your award. Something that's really fascinated me, I'm a zoologist, so I'm not an epidemiologist or that, but I've been puzzled as to why the antibodies of towards the COVID virus actually dropped drastically within potentially 6 months. Is this typical for all diseases, or is this uncannily unusual for this particular virus? And then I've noticed, I've watched reports on television about the once you've had the first or second Pfizer vaccination, the efficacy of that also drops over a period of time. So the puzzle I have is, because I've got a very elementary knowledge of immunology from doing advanced level examinations in England, I always thought there were memory cells which actually picked up afterwards and kicked in if the antibodies dropped. So I'm a little bit puzzled as to why the antibodies drop off quite quickly, or if this is a standard thing for most vaccinations, for example, like yellow fever, or for hepatitis A and B injections.
So thank you very much, Prof. Bennett. And I think your memory of immunology post-vaccination is actually still on target. That yes, with time, antibody levels drop, and what you have is the memory cells, which within a short period of time rise up, and that's the defense that has underpinned our vaccine efforts. The important thing to remember, I think, with COVID-19 vaccines is that they don't prevent infection, but what they do is prevent severe disease and hospitalization. And I think the data coming out of several countries now, UK, Israel, the US, shows that with high vaccination coverage rates, we are seeing declines in hospitalizations. In fact, recently I had the opportunity to interact with some infectious diseases clinicians in France, where the vaccination coverage rates are over 80%. And this is the most striking thing about high vaccination coverage rates, is the reduction in severe disease and illness. And when one looks at who has been promoting these notions of, boosting to elevate the levels of antibodies, it's come from the companies that have already made a lot of money from the vaccines. And so you wonder to what extent market forces are pushing this notion of need for booster dosing beyond those that are highlighted of vulnerable populations, such as those who are immunocompromised and the elderly. And I think this is also one, in fact, the current issue of Lancet has a publication that shows that even with the 2-dose Pfizer vaccine and in the presence of Delta variants, the efficacy remains quite high against severe disease and hospitalizations. So I think there's a bit of disingenuity, for lack of a better word, in terms of how the immune responses and particularly antibody levels are being interpreted and used to motivate for both booster doses. Thank you.
Thank you very much.
Thank you. I don't see any other questions, but I'd like to ask just one, a rather less technical question, but one of the aspects of all of this that interests me and I am involved with is communication about communication of information about the virus, about vaccinations and so on. And we spend a lot of time, of course, on social media looking at anti-vaccine attitudes and misinformation. And I wondered what your view is of what is the best way to counteract the kind of misinformation that misleads people so that they don't go for vaccination. What is your view on that kind of misinformation and misleading communication that we see so much of?
So I think the one thing that COVID has highlighted for me is the importance of science communication beyond the peer-reviewed publications, and the importance of communicating with the public as much as possible. And I think South Africa has taken quite a leadership role here in terms of the president's family meetings. And then we've had at different times scientists presenting new data to the public via TV and so on. And this is not something that happens in many countries, but I think talking to the general public, this has been really valued. And you've seen this in the discourse in South Africa and how that's shifted and where people understand key concepts about the virus. But WHO has described and others this parallel pandemic or the infodemic as it's called, where social media platforms have been used to promote counterfactually based information. And it's always fascinating for me to see how, while this group may not be large in terms of numbers, it has a very loud voice and it has a way of amplifying. And while its presence was quite strong in industrialized countries, we've started to see its presence across the globe. And I'd say, our voices, speaking truth, presenting the fact, presenting it in a way that's accessible, has to be strengthened. And whatever we're doing, we have to do more of that and just get to a point where public understanding of science, the scientific method, in particular, for example, where as scientists, when we thrive on differences of opinion. And when you have and then with time and repetition, we get to a point where our knowledge becomes consistent and what holds until there's some kind of paradigm shift. And how do we bring the public who like things and generally in a form where it's black and white, it's yes and no. But science is never yes and no. All of our knowledge is so provisional. And in public health, we act on provisional knowledge to the best of our ability. And as our knowledge change, we declare that change, and then we change course if that's needed. And how do we communicate that better, this uncertainty, as opposed to, in fact, in life, there are very few things that are black and white, and yet there's expectations, the same, I think, when you say the vaccine is not 100% protective, it's 96% protective, and then they want to know, what about the 4%? Or they interpret it as, for if it's 70%, that we're deliberately going and infecting 30% of the population while we're protecting 70%, which is not the right interpretation of efficacy. So I think it speaks to our efforts that if we are to build a society, if we build populations and communities on evidence, then we have to do a better job in communicating that, so that from a very young age, people start to be able to differentiate between what is true, what is accurate, what is the best that is out there, from what is there as just rabble rousing, or quite frankly, what puzzles me is what is the benefit from the type of misinformation that's there in the face in our country, where we're still seeing high rates of infection, we're seeing people dying from it, and I feel like that should be some kind of crime against humanity.
Yeah, indeed. We have two more questions, and I think these will be the last ones. Patrick, if you would like to go ahead and ask yours.
Thank you again, Chairperson, and congratulations to Prof. My question is that we've actually learned a lesson from HIV and AIDS, particularly here in South Africa, the power and the monopoly in terms of pricing and actually the issues of access to ARVs through the grid of pharmaceutical companies. But then my question is around what are our limitations as a country in terms of producing our own vaccines, in terms of planning and all that? Because this is not the first and this is not the last pandemic that we are actually faced with. What is it? Is it actually a question of technology? Is it a question of know-how and the knowledge? What is it? Why are we not able? I'm also recognizing the latest development of the African Union that is there, but why are we seeming to be lagging behind? Thank you.
Thank you.
Thanks very much, Patrick. It's an excellent question. And I think that with ARVs, we've been able to produce biosimilars at affordable prices, but also that the drug companies themselves have been able to bring the prices down and actually compete with the prices of the biosimilars. But your question around production is, yeah, we should be developing this. This is the whole issue of national self-sufficiency. And it's not something that happens overnight. So it needs a lot of critical steps to be in place. So firstly, there needs to be sufficient political commitment for development. And we've seen that in the countries that I listed. This investment is not something you make in the midst of a crisis. You make it decades before the crisis. And that we have COVID vaccines within within 8 months of us knowing about a pandemic is about these decades of investments these countries have made that have enabled them to build on it and pivot rapidly in the face of a new pandemic. It also needs technical know-how. So now when we're looking at this new mRNA technology, it needs scientific expertise. It also needs technicians. And then when we're looking at production, it's not like a factory where you have a production line. They're very these are sophisticated mega laboratories. And so you need engineers to be able to manage. So this whole cadre of multidisciplinary teams to enable you to do that and produce it. And I'm very excited about the efforts that COVID-19 has highlighted. And it's not just about therapeutics and vaccines and diagnostics, that we have to cover all of these things so that we don't end up in the same situation the next pandemic we face or next epidemic where we're at the end of the queue. And I think our participation in clinical trials have been very important. In HIV, for example, when you participated as a country in a clinical trial, there was some security and surety of post-trial access. In the case of COVID-19, we participated in trials, but unfortunately, there was no guarantee then for post-trial access, either to the trial participants or to the countries where those trials were done. So I think, like the many lessons we've learned with HIV and with TB, with malaria and Ebola, we have to start extracting those and ensuring that, that we don't learn these lessons for one epidemic or pandemic at a time, that we build it so that we get that resilience and we are stronger for whatever. And so the one thing we can go away with is that we can't afford to have another pandemic where this type of knowledge production capability is restricted to a few countries. There has to be more equitable distribution of that knowledge production process for security for all of us. Thank you.
Thank you. And we'll take a final question from Professor Rushdie Hendricks. Please go ahead.
Thank you very much. Can you hear me, Professor?
Yes, we can.
Abdool Karim. Firstly, I would like to congratulate you on a very fascinating and informative talk. And also just to make a comment that in South Africa, we are blessed to have your good self and your husband steering the boat through these very uncertain waters. Excuse me. One question I've got as a health worker is that we were given the J&J vaccine some almost 5-6 months ago. And we are becoming quite nervous now, learning about the reduction in titers of antibodies and so forth. And some colleagues are saying, how about mixing vaccines? How about taking another vaccine like a Pfizer, which has got a booster later on? I was wondering, what would your comment be on the mixing and matching of vaccines? And is there actually any benefit in thinking along these lines, please? Thank you.
Thank you very much, Dr. Hendricks. Excellent, another excellent question. And yes, I think, the J&J we had available, and fortunately the data coming out of J&J from South Africa and other countries are affirming in terms of the high levels of protection it offers. But I think with variants of concern and with time, and as we understand the mix of host responses that are critical for longer term protection, that question of should we be mixing vaccines and how should we be mixing those vaccines, and do we give a J&J and another J&J shot, or do we give a J&J with a Pfizer shot, do we do a Pfizer and a J&J, and so the two vaccines that we are using in South Africa are Pfizer and J&J, and it's a good opportunity for us. And I believe that there's a study currently underway to answer that question. And I would say we need a little bit of patience to wait for the outcome of those studies, because vaccines and boosting and mixing is not just a simple matter of us waking up one day and say, let's do it, it's a great idea. We have to generate the evidence. We have to be comfortable that it's safe to do this, not only for today, but also for the future. And depending on the mix of vaccines we use, should it be heterologous or homologous? What are the implications of that? And these types of studies, which fortunately with COVID, we're able to do in a fairly short space of time, will enable us to make decisions that we know are sound decisions in terms of the evidence that is available.
Thank you.
So thank you. And I think we are at the end of our time. And I think we're all blown away by the comprehensive nature of your ability to explain to us all so many different aspects of this whole COVID time that we are living through. I would like to conclude by just repeating my congratulations to Professor Abdool Karim for her award of the medal. Unfortunately, and you're quite right, we can't actually do this in person with a presentation of the medal and a nice dinner. The good news is that in fact we are planning to reinstate the Royal Society dinners in a slightly different form and hold them in the regions in the near future. So watch the space, they will come. And I hope at some stage we can, in fact, host you for a good dinner. But in the meantime, your lecture has been outstanding, and it simply speaks of the quality that you are able to produce in your research and your very wide knowledge. And it just demonstrates how well deserved the award of our medal is. So again, congratulations. Thank you so much for your talk and for responding to all of those questions. And thank you to everybody who has been here this evening, joined us. I'm sure you've enjoyed it as much as I have, and I'm sure that you'll have learned a great deal. So Professor Karim, thank you so much for all of that, and good evening to everybody. Thank you for joining us, and stay safe and